Good afternoon, everyone. Thank you very much for being here at the end of the day. My name is Deepak Sharma. I am a neuroanesthesiologist at the University of Washington in Seattle. And the topic of my presentation today is perioperative monitoring of cerebral perfusion. Here are my disclosures, and none of this should have a conflict with the presentation today. It's going to be a very straightforward presentation. My goal is to talk a little bit about the importance of perioperative monitoring of cerebral perfusion, get into the little bit of the available technologies for cerebral perfusion, and then their practical value and limitations in actually getting us the information that we need. So to get started, we're all familiar with the cerebral autoregulation curve that we have seen for a while now. But as we understand that this range is not as broad as we always thought. It's probably much more narrower, much like this, and the inflection points are a little more steeper than we thought before. But the idea here is as long as the cerebral blood flow is coupled with cerebral metabolism, indicated on the y-axis here, there is a good coupling and the physiology is maintained. Now, if the cerebral blood flow reduces in the context of reduced cerebral metabolic rate, we have a hypoperfusion setting, but it's not expected to be harmful to the brain. It's when there is a disconnect and you end up a situation where the metabolism is high but the flow is low, we end up getting into the situations of hypoperfusion and potentially ischemia and then infarction. Or on the other side, when the cerebral blood flow exceeds the metabolic demands, we get into the situations of hyperemia. Now, with that said, the physiology is altered a bit under anesthesia. So the anesthetic agents, as we know, they have effects on the brain directly as well as effects on the systemic physiology. They have an effect on the cerebral metabolic rate, cerebral blood flow, cerebral autoregulation, CO2 reactivity, CSF dynamics, and multiple other aspects. In addition, the anesthetics tend to affect the temperature management, the temperature regulation of the body, blood pressure, CO2, all these things, which then indirectly affect the cerebral blood flow. And the net effect obviously is reflected in terms of effects on intracranial pressure, cerebral blood volume, and cerebral perfusion pressure. Now, this is just a healthy individual under anesthesia. Now, you introduce coexisting conditions like long-standing diabetes mellitus, like uncontrolled hypertension, and they can, independent of anesthesia, affect the cerebral autoregulation, cerebral blood flow, and things like that. And then on top of that, we introduce the surgical procedure, which, depending on the nature of procedure, can affect the blood pressure or the cerebral blood flow. I'm sorry. And you can see the interaction can be fairly complex between these factors. So what the anesthetic does to the body, what the coexisting diseases bring, and what the surgical procedure does, then affects the rest of the outcome. So fortunately, perioperative stroke is very uncommon, especially after non-cardiac, non-vascular, non-neurological procedures, to the tune of less than about 1%. The incidence is obviously higher with cardiac procedures, with especially valve surgeries and aortic surgeries, in addition to some carotid procedures. So the risk here is relatively higher, but still in the range of anywhere from 2 to maybe up to 10% for some cardiac surgical procedures. The consequence is obviously significant. Not only is stroke associated with increased 30-day mortality, but it's also associated with a risk for discharge to secondary care facility, long-term cognitive dysfunction, delirium, etc., and obviously healthcare costs. So what are the risk factors for perioperative stroke then? This is a figure from BGA, Dr. Mashore and colleagues. So basically, you can look at this in the context of the predisposing comorbidities here, the perioperative events, and then the procedure itself, somewhat like I was showing in the previous cartoon here. So essentially, older patients, especially women, tend to have a higher predisposition for stroke. Patients who have a history of TIA or stroke, those who have a history of acute renal failure or on dialysis have a higher risk. Similarly, patients who have cardiac disease, hypertension, and are currently using tobacco tend to have a higher risk. In terms of the perioperative events, hypotension and arrhythmia are the obvious ones. We predispose someone to the risk of stroke. but so are anemia, dehydration, and also cessation of antiplatelet agents that the patient might be on for a long period of time, in addition to things like hypercoagulable states, MI, CHF, etc. And then in terms of the surgical procedure itself, as I mentioned earlier, carotid surgery, cardiac surgery, valvular procedures are the ones which are particularly predisposed to this complication. But increasingly, we are learning now that it's not just the overt stroke, but the covert strokes, which are way more common than we ever thought they would be. I'm sure you're aware of the Neurovision study, which was published a few years ago. This is a study conducted across 12 centers in 9 countries, looking at more than 1,000 participants who were more than 65 years of age, undergoing elective non-cardiac surgery, and they all had an MRI after the surgery. And the incidence of perioperative covert stroke in this study was 7%, so substantially high. Now, these patients obviously did not have acute neurological dysfunction in the postoperative period, but what's concerning is that there was a cognitive decline observed at 1 year and also an increased risk of delirium in those patients who had covert stroke. And this study actually recently got published in Anesthesiology this year. It's similar in design to the Neurovision study, but it's interesting in the sense it's a mixed population of non-cardiac surgery population that includes 2/3 of patients who underwent neurosurgical craniotomy. These are all elective procedures. Patients are more than 60 years of age, and these are inpatient procedures. And again, the patients have postoperative MRIs, and they found that patients have about a 12% risk of covert stroke in this study. Again, having a covert stroke doubled the risk of postoperative decline and cognitive dysfunction in the long term for these patients. So what's obvious is overt stroke is relatively uncommon, fortunately, for the most non-cardiac, non-vascular, non-neurosurgical procedures, but covert strokes are more common than we thought they would be, and it seems like there's an association, at least, with long-term neurological dysfunction. So let's talk very briefly about the mechanisms of perioperative brain injury in this sense. So a majority of the strokes, at least, are ischemic strokes. And again, for the context of this presentation, I'm not going to dive into delirium POCD, but focus mostly on strokes. But ischemic strokes tend to be related to an atherosclerotic process in the large arteries, or typically an embolic phenomena. We also see small artery or lacunar infarctions, and some strokes are obviously cryptogenic. On occasions, they might be obviously related to hypotension and hypoperfusion. Hemorrhagic strokes are actually, unfortunately, uncommon, but they may be related to either simply hyperemia or anticoagulation, particularly in the setting of a patient being on a patient having a pre-existing vascular lesion. And especially for the cardiac and vascular procedures, there are specific surgical interventions that tend to then increase the risk of these events, and they include things like putting a cross clamp on the carotid artery, for example, or a cannulation of the aortic arch, etc. So with all that background, we have a number of options that are available to us for perioperative monitoring of the cerebral perfusion, and they're listed here. And I'll just briefly touch upon some of the practical aspects of the commonly used monitors for cerebral perfusion in the clinical settings. So starting very briefly with EEG, again in this context of cerebral ischemia, and not so much in relationship to its association with delirium and cognitive outcomes, which is a significant interest these days. But in context with this topic, EEG is actually sensitive to disruption of neuronal functioning. The advantage is it's non-invasive, it's relatively safe to perform, and it can be performed for longer periods of time, particularly in postoperative situations in ICUs. Where it has been used with some success is patients with carotid surgery, in some patients with post-cardiac arrest coma, and also there's some early interest, I would say, in acute ischemic stroke. The challenge with using EEG, however, is that it is confounded by the age. We know that older patients tend to have smaller amplitudes, and so the EEG may be somewhat tricky to interpret, particularly for someone who is not trained in interpreting EEG. And we also know that this is affected by the anesthetic depth. So increasing anesthetic depth can lead to reduction in amplitudes of the EEG waveforms. So identifying ischemia can become tricky sometimes. I'm sure you've seen figures like this before. On the top is the normal EEG waveform. And as the cerebral blood flow decreases from top to bottom, you start seeing the disappearance of these higher frequencies, and the slower frequencies increasingly become more prominent until we get to a point where we start seeing flattening of the EEG, indicating neuronal damage might start to occur. On the right side here is an example from a carotid surgery. What you have on the y-axis is the brain symmetry index. It's basically looking at the symmetry of the EEG on both sides, both cerebral hemispheres, and seeing if there's a change on the side that has the carotid cross clamp. On the top panel here is a patient where the clamping leads to no change and cerebral perfusion is adequately maintained. But in the bottom, you see that asymmetry actually increases here the moment the clamp goes on. And so this is what triggers the surgeon to place a shunt, which then becomes a bypass source to provide cerebral perfusion. And then the index comes back to normal. And this is an artifact at the end when the shunt is removed. So EEG in these settings can provide guidance to cerebral ischemia with events like cross-clamping of the carotid artery. And it can advise our surgical colleagues to place a shunt, and to us to improve the patient's blood pressure to perfuse through the collaterals if the patient has them. Since this is about perioperative management, I'll very briefly touch upon the interest in the use of EEG in ICUs, specifically in patients with subarachnoid hemorrhage, where there is some data that suggests that the changing ratios of the alpha delta frequencies on EEG, even in patients in post-subarachnoid hemorrhage state, can precede the onset of actual vasospasm and cerebral ischemia. These are different studies that looked at various outcome measures. In this one, just all ischemic events, and this one specifically vasospasm, and these are delayed cerebral ischemia events. But EEG, to some extent, was able to provide an early warning for onset of a major ischemic event. Now, notably, in all these cases, it's the raw EEG that's being used, and that's something that we as anesthesiologists are not very familiar with using. And in the recent years, there's been a significant interest in using processed EEG monitors in the operating rooms, and there has been this interest in exploring whether processed EEG can actually provide some insights into identifying cerebral ischemia. This is a recent scoping review from the Journal of Neurosurgical Anesthesiology, which basically looked at 28 different articles. They're obviously limited. Some of these are just case series, some are small cohort studies. And essentially, what they found was that using one or the other type of proprietary processed EEG measure was not actually effective. So cerebral ischemia cannot be predictably detected using processed EEG monitors, the positive predictive value being really low. Now, whether this has to do something with the type of processing that occurs, or the variability between different monitors, or just the limitation in the number of studies that have been published is difficult. But at this point, processed EEG cannot be used as an ischemia detector. The other monitor that we all tend to commonly use in the neurosurgical operating rooms at least is evoked potential monitoring, where we look at either the somatosensory evoked potentials or the motor evoked potentials to look at the cortical and subcortical tracts and look at the effects of cerebral ischemia. The rule of thumb is that if there's a 50% decrease in the amplitude or 10% increase in the latency of somatosensory evoked potentials, it's considered a significant change, and cerebral ischemia can be an important contributing factor. For motor evoked potentials, a 50 to 80% reduction in amplitude is considered significant and should alert clinicians of ongoing cerebral ischemia and need for intervention. But importantly, as we know, evoked potentials are affected by the anesthetic agents and the dose of anesthetic agents. So that is something that we always have to account for. And obviously, it requires special equipment and expertise There are very few places where anesthesiologists actually do this type of monitoring themselves. Depending on the institution, we participate and collaborate with our neuromonitoring colleagues to interpret these findings. But oftentimes we have to defer to our neuromonitoring colleagues. Now, these studies are actually very old, but we have known for a while, that's the point of citing them here, we have known for a while that there's about a 10 to 20% incidence of symptomatic strokes in aneurysm clipping patients. And this is what led to the increasing use of intraoperative SSEP monitoring to detect cerebral ischemia, specifically in the context of temporary occlusion. So for patients undergoing aneurysm surgery, the surgeons, before they actually place a clip on the aneurysm itself, will place a temporary clip on the feeding artery to get a better control of the aneurysm so they can perform the dissection around it, preserve any perforators, and then place the clip accurately. But it's the placement of this temporary clip that exposes the entire territory distal to the point of occlusion to the risk of ischemia. And so it's important to be able to identify any ongoing ischemia in this setting. And so that's where, at a lot of places, the use of evoked potential monitoring has become almost a standard of care, to the point that now it's so ubiquitous in use that it's hard to demonstrate how much advantage have we had by using these monitors in terms of decreasing the risk of stroke. But essentially, with evoked potential monitoring, it's a prolongation of the central conduction time and a decrease in the cortical SSEP amplitude that reflects ongoing ischemia. So once the surgeon places a clip and you see a significant reduction in the amplitudes, it can guide us to make some corrective measures. On the surgical side, it could be either manipulation of the clip, repositioning it, or getting rid of a pressure on one of the structures there. And on the anesthesiology side, it could indicate the need for hemodynamic optimization in terms of increasing the patient's blood pressure to push the collateral flow through to perfuse the brain. In terms of whether SSEPs or MEPs or both should be used, this is a study that looked at patients undergoing aneurysm surgery, and they looked at different surgical stages and whether or not events were identified based on MEPs or SSEPs. Obviously, this is not the most robust study design because it is difficult to demonstrate how many patients eventually could have been prevented against these issues. But interestingly, at least in this study, they found that in those patients who actually had a postoperative neurological deficit, more than 90% actually had a deterioration in MEP. And in cases of SSCPs, 17% patients demonstrated that change. So obviously, this type of monitoring is predictive, but again, it doesn't really demonstrate how many strokes can be prevented. But that said, based on just anecdotal use, I would say, at least in the cases of cerebrovascular surgery, aneurysm surgery in particular, there's a more obvious utility for this type of monitoring. Here in this slide, you see an example, a case example, a patient I took care of recently, where a posterior communicating artery aneurysm was being clipped. On the left side, you see the somatosensory evoked potentials from the left side of the body, and on the right side are the motor evoked potentials. And if you can appreciate these changes here, you see the somatosensory evoked potentials almost flattened out, and the motor evoked potentials actually completely went away. And this happened shortly after the surgeon had placed the permanent clip, raised the blood pressure a little bit, didn't make much difference, and the surgeon was alarmed again, and they decided to reposition the clip. And at the bottom of these screens here, you can see that both signals actually, somatosensory evoked potentials as well as motor evoked potentials, they came back. And the patient woke up without any neurological deficit. So there is clearly a value in this type of surgery. The other situation where evoked potentials now are increasingly being used are distal aortic repair surgeries. So aortic arch surgeries obviously are associated with an increased risk of cerebral ischemia. And this is a recent retrospective analysis of the institutional practice. But here on top, you see how the collaboration occurs between the neurophysiology team, the anesthesiology team, and the surgeons. anytime they had a signal change, both teams were involved. The anesthesiologist worked on improving the blood pressure or draining the CSF to improve the perfusion pressure. And the surgeons on their end worked at improving the surgical techniques or restoring perfusion. What you see on this graph on the left side are patients who had any postoperative spinal cord ischemia, and on the right side are the patients who had spinal cord ischemia at discharge. Patients who had no loss of evoked potentials had a lower incidence of both of these complications. Patients where only motor evoked potential were lost had a higher risk, but in patients where both motor and sensory evoked potential were lost, the risk of spinal cord ischemia was significantly higher. So again, there is value to using this type of monitoring in aortic arch surgery. When we have this type of monitoring in place, anesthesiologists are closely involved, at least in responding to it. At my institution, we have a policy of calling it a pause, where everybody has to pause what they're doing. We have to have a discussion about the contributing causes. And while the obvious reason might be to simply improve the obvious reason might be just ischemia, we still have to make sure that there are these other confounders that should be taken care of. So making sure the patient is normothermic, normocarbic, there's no positioning issues contributing to it, and then we can work on the blood pressure issues and see if that makes a difference. Just want to mention here that the anesthetic technique can have an effect here, so it's important to not change the anesthetic in the middle of a case. And burst suppression in particular has been shown to affect the quality of signals. So when the signal quality, when the patient is in burst suppression, it might just magnify the changes being seen there. So it's important to make sure the patient is not in burst suppression while we are anticipating this temporary occlusion. But essentially, once this algorithm is taken care of, we can use this to guide management for blood pressure and improve the cerebral perfusion. I'll briefly touch upon near-infrared spectroscopy. The interest here is obviously because it's a non-invasive technology. It requires these sensors that can be placed on the forehead, and they can use optical techniques to provide continuous bedside information about cerebral oxygenation. Essentially, the probe has these light-emitting diodes here, and the reflected signals are captured again, and then the regional oxygen saturation is actually calculated. So basically, the regional oxygen saturation serves as a surrogate of the balance between supply and demand of oxygen. But obviously, the information is limited to the frontal part of the brain, and that's definitely a limitation. Over the years, there has been an improvement, I would say, in the quality of the monitors available commercially. There were significant concerns about the previous monitors not being able to pick the arterial component of blood very effectively. There were even reports of brain-dead patients having adequate values, and that problem, I think, has been technologically resolved for the most part now. But that said, it's still mostly a trend monitor. Rather than focusing on an absolute decrease, a single value of reduction in cerebral oxygenation, it's more important to look at the trends in oxygenation values. So near-infrared spectroscopy has been useful in identifying and then intervening upon cerebral desaturation events in a variety of surgical procedures: cardiopulmonary bypass, aortic arch surgery, carotid endarterectomy, and even some reports of surgery in beach chair position. But importantly enough, and interestingly, these desaturation events have not been related to necessarily strokes. So we might use the monitor to prevent the desaturation events, but studies haven't conclusively shown yet that we will actually reduce the incidence of stroke as a result of this. And there are several possibilities. There is potentially a limitation of the technology, that it doesn't necessarily pick the same level of ischemia. There is significant variability between monitors, as I mentioned earlier. So different monitors are used in different studies, And even the definitions of cerebral desaturations are variable among studies, so it's hard to pool out all of the data and make some definitive conclusions. And then most importantly, I would say the etiology of stroke is multifactorial. If it's an embolic event that's causing the stroke, it may or may not be identified in the real time on this type of monitoring. But again, it's convenient, it's easy to use, and it does help one identify desaturation events in somewhat real time and allows the clinicians to make an intervention to improve upon the oxygenation. This is the recommendation from the American Heart Association. This is their statement on reduction of risk of perioperative stroke in adult patients undergoing cardiac and thoracic aortic operations. And they basically list NIRS as one of the several options, which is basically all the monitors that we've discussed in this presentation. And they don't necessarily recommend that to be used universally for all cardiac procedures. They recommend that a change of more than 20% or an absolute regional oxygen saturation of less than 50% is a significant value and that it should be intervened upon. But again, the data are not conclusive in its ability to detect ischemia. The real interesting aspect of cerebral oxygenation actually is the ability to use cerebral oxygenation for detection of cerebral autoregulation. So cerebral autoregulation, as we saw on the first slide, is this phenomena where the cerebral blood flow remains relatively constant over variable cerebral perfusion pressures or mean arterial pressures. And we can test autoregulation using a variety of devices. Historically, transcranial Doppler has been used, but it's somewhat difficult to use and not so easily available. So a number of other options are available, and near-infrared spectroscopy is something that has been used successfully recently. It has been validated against transcranial Doppler, first of all, to be able to detect cerebral autoregulation, where you basically look at changes in cerebral oxygenation with respect to changes in blood pressure to identify the thresholds where the cerebral blood flow or oxygenation is constant. But this study actually here shows that NIRS can actually be used intraoperatively to detect cerebral autoregulatory limits and identify if the patient is in the autoregulatory range or not. So Dr. Chuck Hogue from Northwestern has done a lot of leading work in this area, and they've taken the advantage of this technology in cardiac surgical patients where you have access to the forehead, you have the ability to look at the cerebral oxygenation. In this study, they basically randomized patients to receive blood pressure management based on either autoregulation guided limits or simply standard care of blood pressure. And their primary outcome measure here was a composite outcome of stroke and ischemia detected on postoperative imaging. Interestingly, they did not find that to be significant, but they found that the patients that were managed using autoregulation guided metrics had a lesser incidence of delirium and better preservation of memory after surgery. And so this led this group to perform a nested randomized controlled trial where they randomized patients to receive standard blood pressure management or autoregulation guided management during cardiac surgery. And they found that optimizing the blood pressure based on the patient's own autoregulatory limits actually led to a reduced incidence of delirium after cardiac surgery. But again, what's intriguing is none of these studies have shown that we're able to reduce the incidence of stroke after these type of procedures. But if you relate this work to the new information about covert strokes that we have based on the Neurovision trial and the recent study in anesthesiology, it's very much possible that we are not detecting these covert strokes. And it's the covert strokes that might be then related to delirium. Talking about cerebral perfusion, I'll very briefly mention the intracranial pressure monitoring. We have the intracranial pressure monitors, but our goal, as we think about it, is to manage the cerebral perfusion. We are trying to make sure the cerebral perfusion pressure, which is the difference between the mean arterial pressure and the intracranial pressure, is adequate to perfuse the brain. So there are a number of ways to monitor the intracranial pressure, and a ventricular drainage device is considered the golden standard, but there are other technologies, including an epidural bolt or a subdural bolt, that can be used to monitor the intracranial pressure. This type of device is commonly used in patients with traumatic brain injury, and according to the current Brain Trauma Foundation guidelines, which are based on not necessarily the best quality evidence, but the recommendation is to maintain the intracranial pressure below 22 millimeters of mercury and maintain the cerebral perfusion pressure in the range of 60 to 70 millimeters of mercury. Now, as is easy to identify here, these monitors are invasive, and they may not be used in all type of procedures in all type of circumstances. So there has been an interest in using non-invasive options to look at the intracranial pressure. Now, obviously, you cannot get the cerebral perfusion pressure information here directly, but one can make inferences. And I would say the greatest interest has been in using transcranial Doppler and more recently optic nerve sheet diameter to measure the intracranial pressure. Especially the optic nerve sheet diameter has been used quite a bit as a screening tool, especially in low resource environments where placing ICP monitors may not be feasible, and also in patients who have coagulopathy and other systemic diseases, where recommending the placement of an ICP monitor may not be possible. Just a word about optic nerve sheet diameter is that there is not a great association between a value and a specific ICP number, but it's more of a trend monitor to demonstrate that there might be an increase in ICP. Although we can use it to detect values where the risk of having an intracranial hypertension episode is higher. Sorry. Monitoring of ICP is important, not necessarily only in patients in the ICU, but there are patients like the one I'm showing in this study here, where the patients have an ICP monitor in place, but they require an extracranial surgery. So we often have patients who have polytrauma and they have to go to the operating room to get an orthopedic procedure or a spine surgery or a laparotomy when they also have an ICP issue or an ongoing issue. And it's not uncommon to see the anesthesiologists actually even disconnect the ICP monitor as the patient arrives in the operating room from the ICU. This is a really small study, and it's hard to argue for anything concrete based on this. But I just want to highlight the fact that at least 50% of the patients have an episode or more of intracranial hypertension or hypotension, cerebral hypotension, meaning CPP less than 50, while getting an extracranial surgery and having an ICP monitor in place. So even in those patients where we have a monitor, there's a good risk of having these type of events. So if your patient has an ICP monitor in place, please continue to monitor it during the extracranial surgery so we can detect periods of intracranial hypertension and cerebral hypoperfusion in a timely manner. Now, brief word about jugular oximetry as a way of monitoring for cerebral oxygenation. For patients undergoing craniotomy, obviously our access to the forehead is very limited, so we cannot use technologies like near-infrared spectroscopy or even transcranial Doppler for the most part. And so there is an interest in using jugular oximetry as a tool to look at the balance between supply and demand of oxygen to the brain. It's also a useful tool in the ICU, but essentially it does not. It basically gives you information about whether the metabolic rate might be too high for the existing cerebral blood flow, or the blood flow might be too low for the existing metabolic state. It doesn't give you the perfect answer for what to fix, but you can look at a few differentials. So the normal range is 55 to 75%, and anything below 50 or 55% is considered cerebral ischemia. So if we see an episode of cerebral desaturation, we tend to think of conditions that are likely to reduce cerebral blood flow or oxygenation. And it could be things like hypotension. And this is not always obvious extreme hypotension, but this could be just relative hypotension, especially in patients with intracranial disease and patients with impaired autoregulation. At the same time, it could be because of conditions like intracranial hypertension or extreme hyperventilation, undesirable hyperventilation. So as we know, hyperventilation helps reduce intracranial pressure, but it does so by causing cerebral vasoconstriction. And too much hyperventilation, or for longer than needed, can lead to reduction of blood flow well beyond the existing metabolic supply for the brain, and that can lead to cerebral ischemia. It can also be seen in patients with vasospasm, but you obviously don't need this type of monitor to detect arterial hypoxia. But on the other hand, there are situations where we see a higher cerebral oxygenation values, and this is where we see cerebral hyperemia, which could simply be because of a reduction in metabolic rate of the brain, situations like burst suppression or hypothermia, where the metabolic need of the brain is really low. But we can also see in situations where there's a true hyperemia in terms of blood flow being above the autoregulatory limits. So that's the information we get from jugular venous oximetry. Here's the examples of tools that one can use. This is a continuous cerebral jugular venous oxygen monitor, and this is basically a long angiocath, a catheter that we often use in our institution to look at cerebral oxygenation by drawing blood gases from arterial as well as venous side at the same time. This is an example from a patient where you have the central line going downwards and the jugular bulb catheter going from below upwards. The positioning is confirmed with the help of an X-ray to identify the tip of the catheter at the level of the mastoid here to make sure we are actually getting the sample out of the brain. This is again an old study, but it basically demonstrated that in patients with traumatic brain injury, a jugular venous saturation of less than 55% is associated with worse outcomes. And so there might be an opportunity to optimize the physiology and cerebral perfusion in these patients. My mentor, Professor Arthur Lamb, popularized the use, at least in our institution and some others, of the use of jugular oximetry during intracranial surgery. Our argument being we do not have access to monitoring cerebral perfusion directly in these cases, but we can always place a catheter in the neck and look at cerebral oxygenation. So that's what we tend to do. This is a very old study, as you can see, 1994. But basically what it shows is based on cerebral oxygenation values, you can titrate your interventions intraoperatively. So on occasions, you see the oxygenation is low, and that's potentially because you're hyperventilating your patient more than you need to. And so we just back off on our hyperventilation, and that helps optimize the oxygenation. But in some cases, we are aggressively hyperventilating our patient, and the surgical conditions are still not good. But if we see the cerebral oxygenation to be adequate, it lets us hyperventilate even more, which is something that we wouldn't do if we did not have this type of monitoring. And in other cases, we use this information to then work on blood pressure parameters or the use of ICP reduction interventions. We've also looked at this in pediatric patients and patients undergoing elective pediatric craniotomy, and about 50% of these patients tend to have at least one episode of intraoperative cerebral desaturation. Again, the problem with this technology is that it's invasive, so it has all the risks that might be associated with a central line placement. But I would imagine that the risk is much reduced with the use of ultrasound these days. But nevertheless, it's an invasive monitor and has to be used very cautiously. But the biggest concern is that there aren't really good studies that have shown an association with the use of this type of monitor and improved patient outcomes. And I think that's tricky because the outcomes in this setting are determined by a number of factors, and it's hard to argue that working on one physiological parameter in isolation can actually make all the difference. But nevertheless, it's a useful tool to help us optimize and maybe individualize blood pressure and CO2 goals during craniotomy. And lastly, I'll briefly touch upon transcranial Doppler ultrasonography. So with TCD, it's possible to look at the cerebral blood flow velocity in the real time on the patient's bedside. It's non-invasive, it's non-radioactive, there's no medications involved, and it's able to give us continuous information about the cerebral blood flow velocity. Importantly, any changes in the patient's physiology are reflected on cerebral blood flow in the real time. So you can give them a medication and see the effect. You can change the ventilation and see the effect in the real time. And that's really the value. It's important to note, though, that transcranial Doppler gives us information about cerebral blood flow velocity and not blood flow. So it works with the assumption that the vessel that we are insunating will maintain a stable caliber. So as long as the caliber of the vessel being insunated is constant, an increase in flow velocity would mean an increase in flow, and a decrease in flow velocity would mean decrease in flow. But there are situations like cerebral vasospasm where the vessel is narrowed, and in this case, we'll have turbulent flow going through that artery, which will be seen as increased flow velocity on transcranial Doppler, but actually it reflects ischemia and not hyperemia. So if you see a higher cerebral blood flow velocity than normal with transcranial Doppler, it could simply be a hyperdynamic circulation, but we would also see this in situations of hypercarbia or with the use of volatile anesthetics, for example. On the other hand, patients who are experiencing intracranial hypertension or cerebral hypoperfusion essentially will have a lower cerebral blood flow velocity. Where we use transcranial Doppler clinically quite a bit is carotid endarterectomy. Again, this is a surgery where you can imagine there's a clamp going on the carotid artery, which exposes the entire cerebral hemisphere to the risk of ischemia. And the desire here is to have real-time information, so we can either optimize the physiology by pharmacological adjustments, or we can make recommendations to the surgeons. This is an example of what might happen when the cross clamp goes on. So what's done here is we insunate the middle cerebral artery, which is the direct branch of the internal carotid artery. But when the cross clamp goes on here, the cerebral blood flow might be reduced only to some extent in some patients, and that's because they have good collateral flow. But in other patients, it might be reduced substantially, indicating there is not any significant flow there, and so we need to have some form of augmentation. You can also imagine that you can give this patient any amount of vasopressor or inotrope you want, and it's not going to make a difference because there is no way that the collateral channels even exist. So these are the patients where the surgeons will typically place a shunt and provide an additional source of blood flow distal to the distal brain. This is a case example. On the left side here, you see the transcranial Doppler waveform right before carotid class clamping. The values we tend to look at are the mean blood flow velocities. In this case, it's 50 centimeters per second. The cross clamp goes on. You can see the waveform is highly dampened, much like our arterial line waveform. And the mean flow velocity is reduced to about 22 centimeters per second. Bottom panel here, a shunt is inserted, and the blood flow velocity comes back to close to normal. And then at this point, the endarterectomy is completed and shunt is withdrawn. This is followed by a period of transient hyperemia, and then the blood flow velocity settles again. So the recommendation here is to look at the pre-clamp cerebral blood flow velocity, and if the post-clamp blood flow velocity is less than 50% of the pre-clamp value, then that would be an indication to use a shunt. There are several studies. One can look at the carotid literature and basically find a study to demonstrate the value of the type of monitoring you want to. There's a lot of variability between centers. Some places use evoked potentials, others use cerebral oximetry, some use transcranial Doppler. And I cite this study because I find it interesting. This is a German study that looked at 50 patients who underwent awake carotid endarterectomy, and they had all these type of monitors on at the same time. They had transcranial Doppler, they had cerebral oximetry, they had stump pressures. And essentially what they found was that a % decrease in cerebral blood flow velocity or a % decrease in cerebral oxygenation was the best indicator with a clinical deficit that this awake patient would experience when the cross clamp goes on. So NIRS works great in this setting, so does TCD, but the problem with TCD is it's technically challenging, difficult to perform, and especially in older patients, there can be a hyperostosis of the bone, so it can be difficult to get the signals. But cerebral oximetry is something that can be easily incorporated into the anesthetic without too much difficulty. The unique advantage of transcranial Doppler is that it's able to give us information about microemboli, which we don't see with any other type of monitor. This is a typical low velocity waveform, and emboli show up as these high intensity transient signals. They also tend to make a large sound, and one can detect these. I'll show you an example of a bubble study. So in my institution, we use transcranial Doppler to look at to do the bubble studies instead of echocardiograms. So basically, we're looking at the middle cerebral artery. We inject agitated saline into the antecubital vein, and if there's a right to left shunt, the emboli will show up in the brain. And I'll show you a brief example of what it looks like here. And that's the shower. So that's a unique advantage of transcranial Doppler. The other unique advantage is that with this you can not only detect ischemia, but you can also detect hyperemia, which is relevant in some clinical settings like carotid endarterectomy. So if a patient has had a long-standing carotid occlusion, the cerebral autoregulation is impaired on that side as a result of compensatory mechanisms. But when the perfusion is restored, then even at normal or relatively normal blood pressures, the cerebral blood flow on that side can be excessive and the brain is not used to handling it. And this can lead to ischemia, which can cause not only hyperemia, but it can also lead to cerebral edema, hemorrhage, and seizures. So the recommendation here is to look at the cerebral blood flow velocity after the endarterectomy is completed. And if it's more than 50% of its baseline and it's sustained for more than 5 minutes, then treatment with antihypertensives is recommended. The other place where this actually is the most widespread use of transcranial Doppler, and this is in the setting of cerebral vasospasm. So patients with subarachnoid hemorrhage are at the risk of cerebral vasospasm anytime starting 3 days after the hemorrhage to up to 21 days. Transcranial Doppler, again, being a non-invasive technique that can be used on the patient's bedside, is able to identify vasospasm, at least in the middle cerebral artery vasospasm, fairly reliably. So you can see here the negative and predictive values, and it's this high negative predictive value which makes it a good screening test. So if your patient is post-subarachnoid hemorrhage, they have an increasing cerebral blood flow velocity, and they fit the criteria for vasospasm, then they might be candidates to be exposed to either cerebral angiography to maybe confirm the diagnosis or to make an intervention. Transcranial Doppler is obviously tricky and difficult to perform, but the robotic transcranial Doppler is now here. There are initial reports. So you don't actually rely on an operator to actually perform it. You can place the device and it's able to automatically insonate at multiple depths and identify which artery it's looking at. And as an operator, you have to just identify which one you're interested in, and it can then continue to give the real-time information. With the patient movement, these monitors are able to adjust themselves and re-identify the signal. And there's some initial success with these type of monitors. But more to come on that. And just a plug for my own lab, what we have done here is just to meet the challenge of training providers in performing a transcranial Doppler, we have successfully built a transcranial Doppler simulator where we took real patients with cerebral vasospasm who have a CT angiogram and a transcranial Doppler, and we superimposed those and put all those case studies in these simulators. And as you can see here, you can put a probe on on the mannequin and then get real-time feedback, much like an echo simulator if you've used that. And this can be used to train physicians and sonographers without necessarily exposing the patients to the risk of this. So in summary, there is a growing evidence, I would say, of the utility of neuromonitoring for cerebral perfusion. It may be particularly valuable in select patients based on their medical and unique surgical characteristics. But the important thing is that there is very limited evidence at this point of being able to reduce the risk of stroke with monitoring-based therapies. We are fortunate that the risk of stroke is not very high, but the concern is the risk of these overt strokes, which tend to be associated with long-term outcomes now. But it's unclear if the use of this monitoring device or these technologies can actually help reduce those problems. At this point, NIRS, cerebral oximetry, seems to offer most promise, but that along with TCD is non-invasive. If my guess is right, we'll see more studies based looking at real-time autoregulation-based therapies in the years to come, and we might see some advantage there. But again, at this point, even autoregulation-based studies have not shown any promise in reducing the risk of stroke, although we see improvement in the risk of other neurological outcomes. So with that, I'll stop. Thank you very much for your attention. Happy to take any questions or assume I was very clear.
Hi, Professor. I have a question about cerebral. Sorry, I have a question. Let me rephrase. I have a question about subarachnoid hemorrhage and vasospasm, post-subarachnoid hemorrhage. So at my hospital, these patients are diagnosed as possibly having vasospasm on MRI brain, and then they go for cerebral digital subtraction angiography to confirm the diagnosis and or treatment. My question is twofold about the transcranial Doppler, which we don't currently have at my hospital. The first one is, do we know if it's as good or better or worse than MRI in detecting possible cerebral vasospasm? And the second question is, what type of clinician would you typically be performing the transcranial Doppler? Is it anesthesiologists or other types of clinicians?
Sure. So the second part, at least in my setting, we have sonographers who do this, but it's a very broad field. There are places where anesthesiologists perform transcranial Doppler examinations. There are other places where it's neurologists, it's intensivists, neurosurgeons. So it's really very, very open field. Your first question, though, with a regular MRI, it's difficult to see vasospasm. You have to have some form of vascular structure, a way to look at the vascular structure. So it'll either have to be a CT angiogram or a MR angiogram of some form, which I would say would be too expensive, too time consuming. It's not something you can do every day. But transcranial Doppler is something you can do on the patient's bedside every day, multiple times a day if you want, right? So it's a great screening tool, as I showed in those meta-analyses. It's a good way to perform a non-invasive study on the patient's bedside and, given the context, select the patients who would then need a more confirmatory study that requires either exposure to radiation like CT angiography or for the sick patient with severe vasospasm to then be transported out of the ICU to cerebral angiography for either confirming the diagnosis or placing a stent or just intra-arterial therapy. So it's very good and robust and well recommended in that setting specifically.
Thank you.
You're welcome. All right, thank you all very much.